So, Bismillahirrahmanirrahim. I am Dr. Vaidali, consultant endocrinologist, working as senior registrar at Jana Post Medical Center, Karachi. Today, we are here for the second session of the newly launched clinical practice guidelines on pituitary adenoma management. And so today's these guidelines also collaborated by the Pakistan Society of Neuro-Oncology as well for today's session. And there are four. I now want to welcome my panelists first. For today's session, our one of the best neurosurgeon of Pakistan and president of Pakistan Pakistan Society of Neuro-Oncology, Professor Dr. Syed Atar Enam Saab, and working in Aga Khan University Hospital. I welcome you, sir. And other panelists for today's session is Professor Dr. Najmul Islam Saab, and working in Aga Khan University Hospital, and one of the best endocrinologists. And he the past president and head of the past president and also the founder member of Pakistan Endocrine Society, Professor Dr. Najmul Islam. Sir, welcome you. But sir will join later on, I think so. Right now, sir have not joined today. And speaker for today's session is Dr.
Professor Nazmul Islam is here now, actually.
Yes, I have joined.
Yes, sir. Sir, welcome you, sir.
Welcome, everybody.
And speaker for president for today's session is Dr. Komal Naim. She leads the study project on brain tumor epidemiology, working in Aga Khan University Hospital, and she will present today on non-functional pituitary adenoma for the second session of the webinar series. And now, before going to pre-poll question answer session, I want to give instruction to participant as well. So there are 4 questions, and each questions have a scenario and 4 detailed options as well. You have to read the scenario briefly, carefully, and then select the correct option according to your best of your knowledge, and then must click the submit button. And in between the question, there are the pictures as well. Please read the scenario and then also look at the picture as well, and then select the best answer according to knowledge. So moving towards the IT team for to share the pre-poll question answer session in front of participants. So this is the first question. Please read it carefully. Twenty-six out of 34, 27 out of 34 participants had attempted this one. 2 are remaining. So this is second question along with picture. Please read it carefully and then see the picture in detail and then attempt the correct one option. 28 participants attempted out of 39. 30. Now moving towards the third question. Please read it carefully and then see the picture. Thirty seconds are remaining. Thirty-two out of 42 participants who attempted this question. 5 seconds more. Now, please share fourth one. Thirty seconds are remaining. Only 24 have attempted this question. Thirty-eight out of 45.
All right, can I start now?
Now, welcome Dr. Komali. Please share the screen in front of our presentation. Okay, good.
Okay, so I'm gonna start. Is that okay?
Yes, ma'am.
All right. Okay, so thank you so much for the invitation. I'm really grateful for the team to working towards it, and thank you so much for showing up on the weekend afternoon. So today will be talking about the non-functioning pituitary adenoma clinical practice guideline. This is done under the collaboration of Pakistan Endocrine Society and Pakistan Society of Neuro-Oncology. I don't have any disclosures. So in November 2018, Lancet Global Health Commission published that 60% of the patient die in LMIC because of the inappropriate or the poor quality of healthcare rather than the availability of the healthcare. And we do see that the health system, we do see there is a huge burden of the patient coming to us. And at that time, it just becomes that more important to provide our patient with the standardized care rather than giving them incomplete or inappropriate care. And that's where the role of the clinical practice guidelines comes in. And I'm really grateful and glad that I get to work on this amazing initiative led by Dr. Aisha Sheikh, and of course under the tutelage of Professor Tharinam, Professor Najmul Islam, and Professor Emeritus Dr. Tasneem Sheikh, and so many other authors who have worked on this amazing project. So with that, I will move to the learning objective of today's session. Of course, the main objective is to get familiarized with the guideline, and so you know what's available in that and what areas have been covered in them. So you can always go back during the clinical practice if you have any certain questions. So of course, we will be going over the non-functioning pituitary adenoma and its diagnosis. And then also what could be the other diagnoses that you need to differentiate it for. And then the second goal is to know what are the treatment modalities that are available. And the third goal is once you have the treatment done, how to follow up those patients. And of course, the cases that were given in the pre-assessment poll, we will be touching upon them as well. So first, we'll start with the non-functioning pituitary adenoma and its definition. So why is it so important? Why are we discussing it here today? Because it is the second most common type of pituitary adenoma after the prolactinoma that we studied last week. But however, it is the most common macroadenoma, which means that the tumor that are greater than size of 1 centimeter, it is one of the most common. It is divided into, if you talk about the classification, there could be two types. A is silent pituitary adenoma, which means that when you do the histopathological exam, so they do test positive, the immunohistochemistry test positive for certain transcription factor, but those hormones are not clinically significant. So they are not producing any symptoms, but when you do the histopathological exam, you will certain positive staining. Versus a null cell adenoma, which is a rare type in which you won't see any positive immunohistochemistry staining. But this is more histopathological or tissue-based diagnosis. Clinically, they presents in the similar sense. Most of them are sporadic, but at the same time, they are associated with certain hereditary syndrome, especially multiple endocrine neoplasia, type 1, type 4, as well as familiar isolated pituitary adenoma. And why is it so important? Because in Pakistan, there is a high prevalence of consanguineous marriages. So when you are taking history of those patients, it is important to touch upon that as well. With that, I will move to the clinical presentation. So most of these patients present with the pituitary insufficiency, actually. 85% of them have pituitary insufficiency, which is very different from the functioning adenoma, in which they usually have some sort of hypersecretion and symptoms related to them. Then comes to the mass effect. And I want to highlight the image here first, that in the center, you see a cellular mass, and in just right above the cellular mass, you see a very worm-like or ribbon-like structure. That's your optic chiasm. So any pituitary tumor, it compresses the optic chiasm, and that's why you see a visual field deficit in those patients. And in the bottom, we can see the result of an OCT, where you can see a bitemporal hemianopsia, which is a classical finding for these tumors. And now headache is also another presenting complaint. So now headache can be a common presenting complaint, but I highlighted it because it is very important to consider other reasons for the headache. There will be very few tumors which are only presenting with headache. Usually there will be some other accompanying symptom. So if your patient only have a headache, then you might want to have a very clear counseling to the patient ke maybe headache is surgery ke baad bhi rahe, maybe this is not the only reason for a headache. So for a headache, you really need to rule out other causes as well. And a lesser common oculomotor nerve palsy can also be seen, but of course, optic nerve is most commonly affected by optic chiasm, or is most commonly affected by it. So now I go back to a case. A 60-year-old male presented to the emergency department with sudden loss of vision and headache, and it's maybe similar to the scenario we just discussed in the pre-assessment. So the patient is coming to the emergency department, which is important, loss of vision, headache, and then you see on the CT that there is certain calcification, which is seen in the cellular mass. You see a white spot, which is basically calcification. And there are also some hypointense segments in that cellular mass, which signifies the hemorrhage or necrosis. So you got the MRI done. And on pituitary MRI done, and on pituitary MRI, you can see that there is a large cellular mass, as well as the hypo intense areas, which signifies the hemorrhage and necrosis. And here you have a better picture of it, and it measures around the 3 centimeter. You also got the hormonal profile done, which is not significant for anything in particular. And then what will be the next step for management? So first of all, the question is, what are we dealing with? So with this, I'll segue towards the pituitary apoplexy first, because it is a very important diagnosis, because it's just कि patient ER में आता है, so the patient comes with a sudden vision loss, severe headache. So it's just a very critical thing that we need to know, that every time we see a patient like that, we need to have it in the back of our mind. Okay, are we dealing with the pituitary apoplexy? Because of course the patient is very sick and very critical. You also would like to see the hormonal deficiencies, and if there are any, especially for cortisol, so you have to replace it, because perioperative management ke liye you have to have all these deficiencies replaced. Also, it is very important to have a multidisciplinary approach for all lesions like this, and this will be a common theme in all of my slides, that multidisciplinary management is very, very important. It is very, very important to discuss these patients with a neurosurgeon, endocrinologist, ophthalmologist, radiation oncologist. And that's why we also collaborated in the guidelines as well, that if we don't discuss the patient, there might be a chance that we are not providing them a good care quality. And it is important to consider कि जहाँ पे भी pituitary apoplexy के patient manage हो रहे हों, you make sure कि they have an emergency neurosurgery care, or which are well equipped, because again, if your center is not well equipped with all the modalities, all the facilities, then you might want to transfer the patient. It is better for the patient safety and better outcomes. Usually, the mainstay of management is surgical resection, and usually preferable is transinsuinoidal. So therefore, we recommended that whenever a patient is coming to you, just make sure that you do a comprehensive clinical assessment, detailed history, clinical exam, ask about the consanguinity, as well as for the pituitary apoplexy. If you are suspecting there is a pituitary apoplexy, then always refer to a neurosurgeon on call. And with that, I'll move towards the evaluation. So if the patient is coming into outpatient setting, and how will you go with the evaluation? Now you have done your clinical history, clinical exam. So the next thing will be an imaging. So this will be done simultaneously. First thing I want to discuss is the imaging protocol. So you want to make sure it's a pituitary MRI. It's not just in a standard cranial MRI. So make sure that you specify when you are ordering MRI कि you need a pituitary MRI. So उसमें minimum जो strength होनी चाहिए 1.5 Tesla होनी चाहिए. It usually have a small field of view, and then you want to have a thin slice with T1 weighted images, pre and post contrast, and T2 weighted image. And volumetric assessment is something that is good to have, but of course, if it's not available, that's fine as well. The second thing is the biochemical evaluation. So again, you want to assess them for the hyposecretion as well as hypersecretion. As we discussed, that most of them do present with the pituitary insufficiency, whereas gonadotrophic deficiency is the most common, followed by somatotrophic, thyrotrophic, and cortitrophic. Also for hyperprolactinemia, so if your patient has a higher prolactin, it is important to consider stalk effect. Not every high prolactin is because of the prolactinoma. So again, you have to keep that in mind. Dr. Aisha really went into a great detail on the stalk effect. So I would encourage you to review that webinar as well, but I will just briefly touch upon it. So dopamine is something that inhibits the prolactin. It's secreted in the hypothalamus, and then it's transferred through the pituitary stalk, and then it inhibits the prolactin. But if you have a mass that is blocking that pituitary stalk, so now the dopamine is not coming to the anterior pituitary and affecting the secretion of prolactin. So therefore, the amount of the prolactin will increase. This prolactin is not secreted by the adenoma itself. It's just increasing because there is no inhibition. So it is very important to keep that in mind. And a lot of time, this prolactin is less than 100. So if you are seeing a macroadenoma, a large tumor greater than 1 centimeter, still the prolactin is less than 100, you should consider that, oh, is it maybe because of the stalk effect? The third thing is to do an ophthalmic evaluation. So if the patient have visual deficit, of course, you have to refer them to an ophthalmologist, and they need to get an OCT done, which is optical coherence tomography. I earlier showed you a picture of that. And also on MRI, if you're seeing that this is the tumor is upping optic chiasm, that you have to order an OCT. Therefore, we recommended that all MRI should be done through the pituitary protocol, and you would have to have an ophthalmic evaluation for all of your patients, as well as the biochemical evaluation for them. So how are you going to manage it? So we're going to start with the what are the modalities that are available. And again, going back to the earlier point, that the management has to be multidisciplinary. It's just that not a one person or one field or subspecialist can decide. You have to discuss the case among the colleagues. So the available treatment modalities are observation, which is good for the asymptomatic microadenoma. Now, microadenoma is anything less than 1 centimeter or 10 millimeter, as shown in the picture of an MRI. It's a microadenoma. So if the tumor is less than 5 and they are 5 millimeter and there are no symptoms, then you can always reassure the patient they don't need any surveillance, but you have to tell them that if there are any development of any new symptoms, then they have to come back and seek care. And it is very, very important to give them a very detailed counseling about the return precautions. And if the tumor size is greater than 5 millimeter, then they do need surveillance imaging at least for 2 years. And if you are not seeing any progression, it is okay to discontinue it. But if you see progression, then of course you have to see if they have symptoms or not, and you might want to consider surgery. Here, I just want to bring a point that for microadenoma that does not have a symptom, it's also similar to microincidentaloma. We will be going into a greater detail later on, but I also wanted to bring up the point here. Therefore, we recommended that we need a multidisciplinary approach for the management, as well as observation is an appropriate treatment modality for the stable asymptomatic microadenoma. Now, I just wanted to discuss a quick case. There is a 52-year-old male. He presented with a mild vision impairment, gait abnormality, and headache. You got the MRIs done, and now you see that there is a contrast enhancing lesion. And again, on the top of the tumor, you see that there is a small worm-like structure or a ribbon-like structure that extending through the superior edge of the tumor. This is your optic chiasm, and it's being compressed. That's why patient is presenting with the visual impairment. And the tumor size is around 3 centimeter, which is a large tumor size. So what workup you're gonna order? Hopefully, you all are either commenting or thinking about getting the biochemical and ophthalmic evaluation done. So what should be the next step? So the next step in cases like these of macroadenoma, surgery is the mainstay and a recommended treatment for these type of tumors. And especially if your patient is coming with the visual field defect, after the surgery, 80 to 93% of the patient reported improvement. So of course, surgery helps with decreasing all the pressure on the optic chiasm, and the patient reports improvement. Hypopituitarism, if the patient has pre-op hypopituitarism, after surgery, around 30% of them reported improvement. It can vary, but that has been the published literature. If there is a mass effect, of course, if there is an increase, sorry, there should be an increase sign here. If there is a increase in intracranial pressure, of course, it's gonna get resolved with the surgery. Again, coming back to headache, it may or may not get resolved completely. So you really have to counsel your patient accordingly. And then for the women who have macroadenoma and they are planning to conceive, regardless of their symptoms, surgery is a preferable option, because during the pregnancy, the tumor size is going to increase. So it's better to take it out before they even conceive. But if they get pregnant, and that's when they after that they discover the tumor, then pregnant women with the visual field defect, it is indicated to have the surgical resection done. But if the tumor is not compressing chiasm, then of course it's a case-based decision. You may or may not wait till the delivery. And then the second more important point for surgery is that, yes, neurosurgeon is the one who's operating on the patient, but you need to have a preoperative endocrinologist evaluation. You want to make sure that all the deficiencies are being replaced. Again, it's good for the patient postoperative outcome. So you want to rule out all the adrenal and thyroid related deficiencies. Approach for the surgery is usually transsphenoidal approach, either microscopic or endoscopic. It doesn't matter. You can use either, or you can even use both in one surgery. It really depends on the surgeon's expertise, what they have been trained on, and how good they are on each modality. So microscope or endoscope, they both are fine. In the inlet, I just wanted to show that what the surgery or the approach looks like. So this is basically an endoscope that you go through the nose, through the nostril, through the nose, through the sphenoid sinus, and that's how you access the sella and you remove the tumor. That's the transsphenoidal approach, and this is the view that you get when you look through the scope. So you go through the sphenoid sinus, you open it, you open the dura, and this is the tumor that they are currently working on. Another approach is cranial approach, that you come through direct through the brain to the head. And of course, TSS has shown better results, but there are certain complicated or complex diseases which mandates both. So you might want to do a two-step surgery where you come through the nose, remove a part of the tumor, and then you come again through the brain and remove the remaining part. So it really depends on the case, what the tumor looks like and how's the invasion, and that's why the pituitary MRI is so important to assess the extension. Therefore, we recommended that surgical resection is the standard treatment for symptomatic NFPAs. Also, you need a preoperative thorough hormonal assessment, as well as the surgical resection is recommended for the pregnant patient with the visual field defect. So now moving on to another case, and this case also kind of binds all the things that we have already discussed. And then also I wanted to discuss another important point through this case. So there is a 65-year-old male presented with a known case of diabetes mellitus type 2, hypertension, ischemic heart disease, unstable angina, and according to the American Society of Anesthesiologists classification 4. Mainly because of the comorbids that he has. He presented with a complaint of progressive vision impairment, vomiting for 8 to 9 months. You get all the hormonal workup done, and there is a increased prolactin. What do you think could be the reason? Hopefully you're all thinking that it is because of the stalk effect, or maybe you want to consider stalk effect before you jump onto the prolactinoma. And this is the MRI that we got done. Again, it's a pituitary MRI. You see a cellular lesion compressing the optic chiasm, and currently it's measuring around 2 centimeters, so a macroadenoma. What do you want to do the next? So what we did next in this, I also wanted to bring up the ASA classification. So ASA classification 4, this is the preoperative classification that given by anesthesia to every patient we operate, surgeons operate on. So ASA 4 means that the patient have severe systematic disease and there is a constant threat to life. So initially we followed up the patient because again, patient has a very high ASA scoring, and it wasn't, the surgeon didn't consider that it's the safest. Although if you think about this case, agar isme comorbids na ho, so the patient should be undergoing surgery. Lekin because of the high-risk surgery, they decided to follow up the patient, and over the 2 years time period, the tumor grew, and now the tumor measures around 2.5 centimeter. So what will be the next thing you will be doing? So in this case, they decided to do the surgical resection, and the patient recovered well and have a very small residue around 6 millimeter around the ICA. So again, I wanted to highlight this last point because again, not all patient is the same. Not every patient is the same. Not for all cases you want to do that serial MRI key and then you want to resect. It's just that in this particular case, that's what the team decided. But in this case, I just wanted to highlight a very important point that it is important, very, very important to consider all the demographic, all the comorbidities that the patient has. It's not just the tumor that you are treating, you want to treat the patient. So you have to take everything in the account. So ASA for 1 to 3, class 1 to 3, it's recommended that the surgery is safe. And also you want to assess के medication history क्या है. Again, it's very important. That's why it's very important to take a very detailed history. If the patient is taking any long-acting anti-clotting agents, so you have to stop it. So for example, warfarin. So you have to stop it 5 days before surgery. And at the same time, start on heparin, which is a short acting. And then after 7 to 14 days, so 1 to 2 weeks after, you can resume the long acting anti-clotting medication. If the patient is already taking antiplatelet medication, it is very, very critical to consult their cardiologist, especially if they have a drug-eluting stent. You don't want to stop it abruptly. So after their consultation, if the cardiologist recommend that, okay, you can go ahead. So for aspirin, you have to stop it 5 days before the surgeries, and for clopidogrel, you have to stop it 10 days before surgery. And again, you can resume it 7 to 10 days after the surgery. So this is something that preoperative optimization that you have to done before the patient undergoes surgery. And for the postoperative monitoring, you have to see that if the patient has preoperative deficiency, then again, you have to see the adrenal functions. Then for serum sodium, you have to do it daily for the first 2 days of surgery. And then also you want to monitor urine output very, very closely. So around 1 to 2 hours during the first and the second day of surgery, and then after that you have to do the daily monitoring. And why is it so important? Again, adrenal function, it's important to ensure a good reserve because of its correlation with the postoperative outcome. Also for serum sodium and urine output, you want to screen for the central diabetes insipidus, SIADH, cerebral salt wasting, which is a known complication after any cranial procedure or any brain procedure. And there is a separate guidelines or a separate chapter on only just the perioperative management. But I just wanted to bring it here as well because it is of a very critical importance. So that's why, so just to sum up, it is important to consider all the comorbidities and the demographics while planning for the surgery. And we recommended that for every sample, so every time you do a surgery, it has to go to the histopathology and you have to have the molecular analysis done. I'll be discussing about it in a little more detail in the medical management, but it is very important that all the tumor, all the lesions that you take out from the brain, they go for the histopathological assessment. And then again, for post-operative, you want to monitor serum sodium, urine output as well. So now I just want to talk a little bit about the giant pituitary adenoma. So far we have discussed the microadenoma, macroadenoma, but now the giant pituitary adenoma. So they are 4 centimeter or greater in size. And since they are so huge, they are usually extending into one or the other region of the brain. So either they can go into the paracellular region, or they can encase the internal carotid artery. They might be extending into the brain or the other region of the brain. So at AKU, the team developed a giant pituitary adenoma score, where depending on their size and their extension into the brain, you give them a certain score. And what's the importance of this score? So this score actually correlates with the percentage of the resection of that tumor. So if you see that, so all the scoring point is according to the extension. If the tumor is extending into the multiple area, there will be the higher score. So you see that for a lower score, the percentage of the resected tumor is higher. And as the score increases, the percentage of the resected tumor decreases. So which again tells us that maybe just doing a single approach is not sufficient. You might want to consider a two-step approach for a tumor which has a higher AQ giant pituitary adenoma score. And therefore, we suggested that it is important to consider transsphenoidal versus transcranial, or maybe both, depending on what's the radiological parameter of that specific patient. So it has to be decided on each patient basis, that what's their tumor look like, kahan pe ja raha hai, and what will be the best approach to deal with that tumor. So that's about the surgery. Now we're going to move towards the radiotherapy. Radiotherapy has really changed the treatment modalities or the treatment paradigm that we have been following in neurosurgery, or for that matter, other subspecialties as well. But having said that, it is still, there are very, very limited for indication where radiotherapy serve as a first line treatment for NFPA. So it is again very, very important. जितने भी size का tumor आए, either 2 or 3 or 4 or 5 or macroadenoma ho, never send them right away for the radiotherapy. It is very important to have them seen by either neurosurgeon, जहाँ से भी आ रहे, depending neurosurgeon or endocrinologist, जहाँ से भी आ रहे, but they have to be seen by them first in order to make a decision. Never send them right away for the radiotherapy. And however, radiotherapy is a good modality when we are dealing with the residual or recurrent tumor, and we'll be talking about that in great detail as well. For a tumor that is less than 3 centimeter, it's an excellent modality. And in radiotherapy, again with the stereotactic radiosurgery, which is a certain type, just you really focus on the lesion only, and you can actually decrease the radiation going to the periphery of the lesion. So you really can focus on the lesion only. And the top picture, it shows the patient in the stereotactic frame, and that's what helps us with really do the precise treatment. And the picture in the bottom shows the machine for the radiosurgery, excuse me. So there can be two modalities. Either it could be single session, in which you just do single dose 12 gray, but you have to make sure that there is at least a minimum distance of 2 millimeter from the optic chiasm, and the maximum dose to chiasm in this single session radiosurgery is 8 gray, versus fractionated doses. So you can actually break down radiation into certain fraction. The recommended is to have 25 session So 1.8 to 2 gray session in 2 gray radiation in each session, and then the cumulative dose will be 45 to 54 gray. And this can also be considered for tumor that are actually closer to the chiasm. So complication of the radiotherapy. So of course, we do have a separate chapter for radiotherapy as well, but I also wanted to bring it here because again, surgery and radio surgery for NFPAs are done quite commonly. So the most common is hypopituitarism, and that's why I highlighted it as well. And it is very important to screen those patients for the hypopituitarism once they undergo the radiotherapy. Other lesser common side effects could be optic neuropathy, secondary tumor, or vascular complication. Again, SRS with the stereotactic radiosurgery, it can actually decrease the rate of these complications. And then the third option that is available with the NFPA is medical therapy. Mainstay of the treatment is temozolomide, but again, it's not something routinely done, and you really have to have a very good discussion with the oncologist that what the tumor look like, what has been the treatment planning so far, and what are your goals with the treatment. So it's usually reserved for a very aggressive recurrent tumor that is not responding to any other interventions. You are done with the surgery, you have done the radio surgery, but it's just that the tumor is very aggressive and continues to grow. Also, for the tumor that have higher Ki67, that is greater than 3% or positive P53 and have mitosis that is greater than 2 per 10 high power field, those tumor are more likely to recur. And again, these things you're going to know through the histopathological exam. These tumors like to recur, and if they recur, then temozolomide is a good treatment agent. You want to assess the response after 3 cycles. So each cycle is around 28 days. So you want to reassess after 3 cycles. And if you get a positive response and the tumor is shrinking or responding to the treatment, then you can continue it up till 6 months. But again, you have to consult the oncologist for a definitive treatment plan. Also, temozolomide has better outcome if the tumor has lower expression of MGMT, but again, MGMT is something not routinely done in Pakistan. So just to recap, so far we have discussed that we have radiotherapy available, single dose versus fractionated, and then if you want to consider radiotherapy, it is better if there is at least 2 millimeter gap between the tumor and the optic chiasm, and medical therapy is an available treatment modality for an aggressive tumor. So this is the algorithm that we publish in the manuscript, and it just really go over or summarize all the points that we have previously discussed. So from there, I'm gonna move to another case. So a 53-year-old woman underwent an MRI during the evaluation of the syncopal episode. So now we are seeing this patient who got an MRI done. And if you notice, this is not a pituitary MRI. This is a standard brain MRI. And then they saw a abnormality in the cellular region. And now you are seeing the patient. So what will be the next step? So first, of course, the question will be, what are we dealing with? So a pituitary incidentaloma is basically when you discover the adenoma on the imaging that is done for unrelated causes. So syncope is not something that pituitary adenoma patient present as. So they wanted to rule out other conditions, and then they found this. So how are you going to proceed with those patients? So again, going back to the basic, you have to have a very good clinical assessment, detailed history. In biochemical evaluation, you don't have to start with the entire panel. You can actually do a very limited screening. So prolactin IGF, overnight dexamethasone suppression test. And then if you see any abnormality, you can do a detailed panel. And for radiology, you have to have a pituitary MRI. That was the brain MRI. You now have to do a pituitary MRI, and this pituitary MRI will be very important because it will serve as a baseline when you will do a serial imaging or surveillance for those patients. And if you see that once you get the pituitary MRI done and you see that the tumor is actually compressing the chiasm, then in those cases you have to order a OCT or the ophthalmologic evaluation. So this is the algorithm that we published in our manuscript as well. So for incidentaloma, you have to do a clinical assessment, and if you see any hypersecretion in those biochemical evaluation, you have to treat you have to treat them as well. So for microincidentaloma, if you see that the size is less than 5, you can always reassure them with the return precautions, which is again similar to the observation thing that we discussed earlier. But if you are seeing that the patient has high tumor size 5 to 10, then you follow them up for 2 years with MRI. And if you don't see any progression, you can discontinue the surveillance. But again, you have to tell them when to return. But if you see progression, then you get an annual, then you need to get annual MRIs done. And when do you want to consider a surgical excision? When the tumor is affecting the chiasm, or there is a loss of endocrinological function, or hypersecretion in some cases, but of course not for prolactin. If you see a prolactin hypersecretion, surgery won't be a first line. And if the patient is complaining of persistent headache, again, you want to consider surgery. Then we go back to the macroincidentaloma. You again have to have a MRI with pituitary protocol, and you're gonna see, so these patients do not have symptoms, but now they have a macroadenoma. So what you're gonna do? You're gonna see what's the distance from the chiasm. If it's greater than 5 millimeter, then you have to have a radiological and biochemical surveillance. For radiological surveillance, you have to get an MRI done at the 6 months follow-up, and then after every 2 to 3 years, you need to get the MRI done because again, the tumor is closer to chiasm. And if you don't see any progression, then you can just continue to do the radiological surveillance. But if you see progression, now you also have to repeat the biochemical evaluation as well as ophthalmic evaluation. And again, if you continue to see the progression and the tumor is abutting the chiasm, so you might want to consider surgery for those patients. And for the patients whose tumor is more than 5 millimeter away from the chiasm, then you don't have to, you just do the, you don't have to do, you do the ophthalmic exam and just see कि उनकी क्या findings हैं और tumor जो है वो progress कर रहा है या नहीं कर रहा है, and just continue to follow them out. So this is just a brief, and of course you can go into the detailed reading of the incidentaloma. So these are the recommendation that we put forward in our manuscript for the incidentaloma. So just wanted to quickly cover the incidentaloma, and now I'm gonna go into detail towards surveillance or response evaluation कैसे करनी है. But before that, I just want to clarify one thing, that these are just guidelines and they are supposed to provide you with the framework. Every patient is different, so you have to decide accordingly. लेकिन यहाँ पे we just want to give you what should be at least done for these patients. So we'll start with so now these patients have undergone surgery and now you want to do a surveillance. So वो कैसे करेंगे? So for biochemical surveillance, you just do every 3 months initially for a year, and then you can do 6 to 12 months depending again कि क्या क्या deficiencies थी या क्या क्या treatment चल रही है and how you want to monitor that. And if there is no deficiency, then it can actually discontinue, especially अगर कोई tumor remnant भी नहीं है after surgery. Or adrenal function I just want to highlight it here again. You have to screen it, you have to assess it 2 days after surgery, within 2 days of surgery, 4 to 6 weeks after surgery, and 10, 12 weeks. And similarly for thyrotropin deficiency, if the patient has pre-op deficiency, and now you want to assess that if patient has recovered or not, you have to stop thyroxine at least for a month before you repeat those tests. Then for radiological surveillance, you have to do a pituitary MRI. Again, it's important to follow the pituitary protocol. We recommend that preferably it's done at the same center, because again, all the parameter, all the machine that is the same. So जब भी हमारे पास result आ रहा है, it's easier to compare, and it's very, very important to compare all the scans when you are reviewing patients like these. Again, the timeline would be that you do an immediate post-op, then 3 to 6 months after the surgery. It's not recommended to do before 3 months because there are a lot of post-surgical changes. Then at 1 year, then you do it for 5 years. Yearly, you do it for 5 years. And if you are not seeing any recurrence or remnant, so you can do it 7, 10, and then 15 years, and then you can increase the interval to 5 years. But if you are seeing any remnant and you are suspecting some progression, then you have to do it more closely, that is 2 to 3 years. Ophthalmic surveillance. So there is no specified length that you have to follow those patients, but if there is a visual impairment, you have to do it at 3-month follow-up, and then you have to do it at every 6 months, and again follow up with the ophthalmologist and see what they have to say about that patient. And if there is no visual impairment and the remnant is not close to the chiasm, then you don't have to do any surveillance. But for the cases where the patient got surgery done, have a remnant, got the radiosurgery done, then you have to do a long-term follow-up, because again, with the radiosurgery, there is a complication, a radiation-induced optic neuropathy, so you have to screen for that. So again, the surveillance we suggest is for biochemical, you do 3 months and then 6 to 12 months. For imaging, we have a certain intervals. And then for ophthalmologic, we also advise a certain follow-up. So this brings me towards the few last recommendation of this paper. So teleconsultation. We did a study where we studied all the brain tumor patients in 2019 called the Pakistan Brain Tumor Epidemiology Study, and we found that 41% of patients were lost to follow-up, that they didn't come back and didn't receive the entire treatment. And when we saw, especially for the pituitary adenoma, it actually increases. So 43% of patients are lost to follow-up. And it's important to see and know the reasons that what could be it. So we know that a lot of our patients are just coming to us just to get their results review. So maybe for follow-up, if we are seeing patients, either their affordability issue or their issue with the distance being traveled, so maybe we can offer the teleconsultation where we just we don't have to be here physically, and we can advise them accordingly. Whatever their result finding is, uske accordingly हम उन्हें advise कर सकें. So that's why we recommend for the teleconsultation if we are suspecting कि patient नहीं follow up कर पाएगा. Now going towards the residual tumor. So again, as discussed earlier, that adjuvant therapy, which is mainly radiotherapy, ensures good disease control, and at 10-year follow-up, there was a disease control of 90%. And again, there is a debate about delayed versus immediate radiotherapy, but with 6 months radiotherapy that is delayed, that has a better complication profile as compared to an immediate radiotherapy. But again, it depends on the patient. They both are equivocal. Factors that you want to consider for radiotherapy in residual tumor, that what's the tumor size, tumor kitni tezi se बढ़ रहा है, what's the patient compliance. So these are all the things that you would like to consider before you decide for the radiosurgery. Also, surgery is usually limited for the patient who have symptomatic remnant and is rapidly growing. So you would like to do a surgery rather than radiosurgery. And if the residual tumor is only small, intracellular, without the cellular compartment, you don't have to do any intervention, and you can do imaging surveillance. And for recurrence, resection versus radiotherapy, they both can be considered because we feel like it's better adaptability. Pakistan mein hai कि if we either offer them radiotherapy या resection, तो वो radiotherapy को ज़्यादा prefer करते हैं. It's just have a better adaptability. But again, for adjuvant radiotherapy, you want to make sure कि there is a margin. Safe margin of 3 to 5 millimeter, or surgery में you can also consider a two-step अप्रोच. अगर जैसे रिकरेंस जो हुई है वो बहुत बड़ी आ रही है या साइज बहुत तेजी से बड़ा हो रहा है, so you can always go two step. So teleconsultation, what we recommend for our patients to improve the loss to follow up, and then for these are the recommendations for the residual, and then again coming back to the multidisciplinary decision that's need to be made. And this is the, again, tumor surveillance that we have discussed. This is the algorithm that we have included in our manuscript. So these are my references. And with that, I would just like to thank you, the entire team, and especially the authors that contributed to this paper. And thank you, everyone.
Thank you, Dr. Komali, for such a nice presentation and covering each and every object in details. So now we're moving towards the post-poll session, and our participants are ready to answer. So please, at the time, please share the post-poll session for our participants. Now you can change your answer as well. Forty seconds are remaining. Please try to answer as early as possible. $28 out of 44. $20 seconds are remaining. Please try to answer as early as possible. Five seconds are remaining. Okay, now moving towards the second question. Thirty seconds are remaining. 28 persons have attempted this question. Twenty seconds are remaining. Please try. Please attempt as early as possible, please. Now moving towards the third question. Please share. 40 seconds are remaining. Only 14 persons have attempted this question. 18, 19. Fifteen seconds are remaining. Moving toward the fourth one. Please share the screen. Thirty seconds are remaining. Only 19 participants out of 43 who attempted this question. Okay. I think post session has been completed. Now I'll request to participate, please write down the answer. Any person who want to ask questions, please write down the question and answer session. Till then, we will take the comments from our panelists. So I would like to request Professor Najmul Islam, please share their clinical experience about non-fungal pituitary adenoma.
Assalamu alaikum, and everybody. It was a nice presentation, comprehensive by the speaker really on this topic of non-functioning pituitary adenoma. She has stressed on this point that these cases should be discussed in the multidisciplinary meetings, which is MDT, and we have pituitary MDT in AKU, but other institutions should also start this activity in their institutions so that all patients are, the management of all these patients are decided with mutual consultations and agreement. Non-functioning pituitary adenoma, from my point of view as an endocrinologist, is something that I'm concerned that actually it should be a non-functioning pituitary adenoma, and it should not be by mistake a functioning adenoma, which is assumed as non-functioning, because there are certain things that has to be excluded. For example, a prolactinoma is very important because it is treated medically, and then there's something like a stock effect has been stressed, and it was stressed by Dr. Aisha as well in the previous presentation. But sometimes you have this effect where you have to ask for a dilution of the sample when the pituitary tumor is there and the prolactin is modestly raised, and that does not correspond to the size of the tumor. You have to request the lab for measuring the prolactin after dilution, and that may show a very high level of prolactin, and that makes it a prolactinoma, and the treatment is medical to begin with rather than surgical. Rest of the things have been nicely highlighted by the speaker, and the things that have, and Dr. Athar Inam is here and he can comment on the surgical aspects. But and the second thing that we endocrinologists have to take care of these tumors is the hypofunction of the pituitary gland, the pituitary hypopituitarism. because we have to manage their replacement adequately as and when it arises. In post-operative patients, immediately we have to follow them, and patients who had radiosurgery, we have to follow them, which may develop even later. So these are important points from an endocrine perspective. And I think Dr. Adenoma will have rest of the things to say on this topic.
Thank you, sir. Thank you for your valuable comments, sir. I would like to request Professor Dr. Adenoma sir to please share your valuable comments and experience for today's session.
Thank you, Dr. Wajid. So this was a very well presented talk. And once again, it reminds us that how when people come together, this guideline that was put forth, compiled and put forth by PES and PASNO and all the people working on it is and obviously Dr. Komal did a very good justice to her this topic, and her presentation was fantastic. I think all the points I could discuss, Dr. Nazrul Islam has also stressed on the point of multidisciplinary approach to these things. From surgical perspective, the nuances of actually surgical things that are part of the training, but in general, what I can say that if the tumor is is not invading into the cavernous sinus, then microscopic versus endoscopic approach is has the same outcome. But when it's invading the cavernous sinus, has a slight superiority over the microscopic approach. But then when it's beyond the cavernous sinus, it's in the places. This is pretty much what Dr. Komal has mentioned. I just wanted to reinforce that.
Dr. Athar, we can't hear
Voice-
you.
अब आ रही आवाज?
So voice is, please speak loudly. Voice is not clear.
Can you hear now?
Yes, sir. Yes, it's
Okay,
clear
sorry.
now.
My apologies. Actually, I had to move away from my room. So now I was talking about the approach by surgeons. So initially, my approach used to be that we need to remove each and every bit of the tumor, but I have changed that now. Now, more important thing is to make sure that the pressure is off from the optic chiasm, and if you can remove the whole tumor, that's perfectly fine. But in that process, don't do any damage to the surrounding tissues. You're always you can always use radiosurgery for residual. The most important aspect of non-functioning pituitary adenoma is to remove the pressure from the nerves. So those are the 2 points that I wanted to mention. The Komal, you agree, right, on that one? Yeah. Okay. All right. Jay.
So there's one question for our panelists. If a female unmarried, non-pregnant has a prolactin level less than 100, but higher than normal associated with amenorrhea as well, should undergo for MRI evolution or not?
Let me answer this question. I mean, obviously, she has to see a physician who can go into the history, whether this high prolactin level is causing any problems to her or not, whether this is a prolactin or macroprolactin, because macroprolactin is not very effective at all. It is not an active prolactin, which does not cause any problems. But an active prolactin levels, if it is raised, will lead to amenorrhea as well as galactorrhea in females. So those things have to be decided in the history. And then the second thing that have to be decided is there any medications that may have caused hyperprolactinemia. And if we have excluded all the possible medications that causes hyperprolactinemia. And then the third thing is then only we should be considering an MRI of the pituitary gland to see if it's a prolactinoma. I think it has to be a stepwise approach, a consultation by endocrinologist who digs into the history, rules out the medications causing hyperprolactinemia, and then orders the MRI of the pituitary for prolactinoma.
Nomara, you understand, I think so your answer question will be clear, but pre-poll and post-poll comparison is ready, so please share IT team in front of us. If any person have question, please write down in the question answer session. So this is a response our participant have done, in which the second option is clear in first question, in which difference between function and non-function pituitary adenoma was asked. I think so most of the participants have answered correctly. Madam, your valuable comments. Please unmute Dr. Komal name.
Yes, I just want to make a point कि we see the difference in pre and post कि fourth में ज़्यादा comments आए हुए थे. So yes, I think they were confusing incidentaloma with the non-functioning pituitary adenoma. So but post session में you see कि they are clear now कि incidentaloma is the one जिसमें symptoms नहीं आएंगे, but non-functioning pituitary adenoma is just कि hormonal जो है या उनके biochemical evaluation में you might not see कि उससे रिलेटेड कोई सिम्टम्स नहीं होंगे बट स्टिल दिल हैव हेडेक या प्रेशर रिलेटेड सिम्टम्स और डॉक्टर अथर ने भी उस पर बात की कि इन सर्जरी दैट्स व्हाट वी आर टारगेटिंग दैट द प्रेशर रिलेटेड सिम्टम्स आर रिलीव्ड इन दोस पेशेंट्स.
Please share second question response, please. Now, in which response is equal. I think so pre-poll and post-poll response is same. And 21 and 20. 21 have attempted in second session, they have attempted less compared to previous one.
Yeah, so yeah, I think maybe it's just the CT scan. Again, that's why I put it there, that you really have to review the images. And of course, it doesn't matter that what subspecialty do you belong to, endocrinology, neurosurgery, radiation oncology, जो भी यहाँ पे attend करें, but they need to familiarize themselves with the CT, with the MRI, कि how does the cellular lesion look like, and pituitary apoplexy में what are the things that you are noticing. So अगर मैं post session में देखूं, so I do see कि अच्छा लोग सो यहाँ पे जैसे MRI 4 weeks में आप रिपीट नहीं कराएंगे, सो मे बी MRI विद एंड विदाउट साइंडेड के हाँ वो करवाना चाहिए, बट 4 weeks में नहीं कराएंगे. यू हैव टू गेट इट अर्जेंट बिकॉज अगेन पेशेंट ED में आ रहा है, सडन विजन लॉस है, सो यू हैव टू अंडरस्टैंड द अर्जेंसी. एंड ठीक है, लास्ट वाला भी ऑप्शन लोगों ने ज्यादा किया है पोस्ट में, बट अगेन यू हैव टू एनालाइज कि इसमें आउट पेशेंट लिखा हुआ है, दैट मीन्स कि यू आर सेंडिंग पेशेंट होम. सो इमरजेंसी डिपार्टमेंट ने सडन विजन लॉस के साथ आया है, डू यू वांट टू सेंड देम होम और डू यू वांट टू स्टार्ट डूइंग थिंग्स जब तक वो हॉस्पिटल में है. सो दैट वाज द डिफरेंस एंड दैट्स द सेंस ऑफ अर्जेंसी दैट यू नीड टू गेट विद दिस केस.
Okay, madam, thank you. Very well explained. Please share the third question response, please. In which there is a, in which also the almost similar response is compared to pre-poll, but overall attempted less number of participants compared to previous one.
So again, इसमें भी वही बात है कि sometimes we just get too fixed towards के hormonal मतलब hormones में क्या है, prolactin कितना है, cortisol कितना है, which are very important. I'm not taking away importance from them. But again, you need to familiarize yourself with the OCT as well. कि अगर ये patient आपके पास लेकर आ रहा है, which a lot of these patients do have, cellular lesion है, तो इसके साथ वो report भी ला रहे हैं. So just you need to just know कि जब मैं ये देखूं OCT तो उसमें what am I looking for, and that's why I included this picture. मैंने कोई MRI की picture नहीं डाली, कोई hormones की detail नहीं डाली. The goal was कि you also familiarize yourself with the पिक्चर. अच्छा, उसमें आई सी के फर्स्ट वाले में ज्यादा आ गया है, बट अगेन इफ यू सी इट्स अ मैक्रो एडिनोमा, इट्स सेज 15 मिलीमीटर, सो दैट मीन्स कि 1 सेंटीमीटर से बड़ा है. एंड जब भी कोई NFPA हार्मोनल प्रोफाइल मतलब हार्मोन्स में आपको कोई खास चीज नहीं मिल रही, फंक्शनिंग नहीं है, जब भी NFPA है और उसमें बाइटेम्पोरल हेमियोनोप्सिया है, दैट मीन्स के विजुअल सिम्टम्स आ रहे हैं. So definitely, surgical resection is something that is preferable.
Please share the fourth one. Fourth questions response, please. In which most of the participants have attempted correctly. Almost 30% pre and post poll. Now round about same in pre and post poll. Please, madam, share your valuable comments on this scenario.
Again, इसमें बस ये the goal was to कि जब मैंने इस question को डाला, the goal was that you are familiar with the surveillance and follow-up कैसे होता है, and this is a case that you might be seeing a lot in your clinic. एक patient था, macroadenoma था, surgery हो गई, radiotherapy हो गई, और remnant भी है थोड़ा सा. So how you gonna proceed now? So of course you would like to do a closer follow-up, and again these are just guidelines. Maybe आपका जो duration है वो थोड़ा सा different हो जाए, but the goal is to have a closer follow-up. Now the first one was कि 1 year पे, फिर 10 year पे, फिर 15 year पे. That's a very spaced follow-up, and you will miss a lot of recurrence and progression अगर आप इतना दूर कराएंगे. So the goal is to just have a very close follow-up.
Now, any participant want to ask question, please write down the question answer session. Otherwise, any comment from panelist? Otherwise, we will want to conclude the program. Any question answer from panelists?
No, I think people who are attending may have questions. Please ask them, give them the opportunity to ask.
There is no question and answer session. No question and answer session.
Okay, if there are no questions, then I think it's time to wind up the meeting.
Okay, sir. Thank you. I would like to thank our esteemed panelist speaker for arranging such a nice presentation and a session for panelists and participants as well. And especially thankful to Sir Atarinam sir for valuable comments. And have a good day. Thank you.
I would like to thank Komal for the presentation, and I would like you to thank you as well for the moderation.
Thank you, sir. Thank you.
Obviously, my colleague Atharinam for his presence.
Thank
Because
you,
in
sir.
fact, this is his main topic rather than ours. But I hope Athar is here or is left.
Sir, to the left, sir.
Okay. Chale, take care. Thank you, everybody. Khuda Hafiz.
Thank you, sir. Thank you, all of you.
Thank you, everyone.
Allah
Allah
Hafiz.
Hafiz.